I need to report. That's the one we want. Lauren Swabish is the owner of Neurospeech Services, a private practice based in Northern Virginia, specializing in person-centered assessment and treatment of cognitive communicative disorders related to stroke, acquired brain injury, mild cognitive impairment, ADHD, and other neurologic and neurodegenerative conditions. She received her Bachelor of Science degree with honors in communicative disorders from the University of Wisconsin-Madison and holds a master's degree in communication sciences from Hunter College of the City University of New York. She is licensed in the Commonwealth of Virginia and the state of Maryland and is a certified member of the American Speech Language Hearing Association. And she has over 25 years of experience working in hospitals and acute rehabilitation centers and is passionate about providing meaningful and accessible care, health education, and care about the brain to patients, families, and healthcare professionals. Lauren is committed to empowering communities with evidence-based information and best practices in brain health behaviors. And we are so excited here at Insight to be working with Lauren today, just trying to move the slide along to show a little bit about us, but that will work on that one, my screen. Okay, just letting you know that our mission at Insight is always related to making sure that we have given dignity to all of those experiencing dementia. We are trying to make sure that we support all families and caregivers, and today's presentation is exactly that. I'm going to switch us over to see her screen in a moment. Stop sharing mine. There we go. And we're learning today about swallowing and eating changes in the dementia journey. And I want to just turn it over to Lauren. Do know that we have a webinar in place. If you have questions, please put them in the chat and we'll do everything we can to answer those questions, especially sometime at the end of our presentation. Ms. Swabish.
Unmute myself. Can I just make sure that people online can hear me? And we'll turn that off. Okay. I hope people can hear me.
I think so.
Okay, good. Thank you for taking time to, okay, we got a thumbs up. Perfect. Okay. I think that eating and commuting together is so important. And so I'm really excited to kind of help paint a picture about some of the changes that we expect with normal aging and then some changes that we need to be mindful of in the context of brain changes as they happen as a result of dementia. My background, I've owned a private practice just for a handful of years now, about 4 years, but my background is really in hospital-based rehabilitation. So really understanding that sort of medical model of evaluation and treatment and what that looks like. So I have that information, but then I'm privileged to work in the community now with people in home. And so have been following a lot of families along this journey. So for today, our agenda is really going to be kind of giving you some education on how the swallowing process works. I think like a lot of things, we take it for granted until it's not functioning the way we expect it to. So a little overview there. We're going to talk about changes that impact with age, things to be watchful for in the context of dementia, mostly some recommendations about how to maintain safe swallowing for as long as possible, and then some end-of-life considerations when it comes to nutrition. So again, eating is such a wonderful way to sustain our bodies and to enjoy the flavors we like and the cultures that are meaningful for us. So this is a really important thing to be focusing on as we try to maintain that as part of that Insight's, desire to maintain dignity, but also for ourselves to just be able to enjoy the things that really bring us so much happiness, and also community, because eating is a highly social activity. When we get together with friends and family, we meet for coffee, we go out for lunch, we have holidays. So feeding and eating are really integral to our experience as people. So when we think about swallowing, we really want to get a little bit of kind of anatomy and physiology in place. I think that really helps me as a clinician to understand what I'm looking at. And then it helps people to understand when we do apply interventions, what those look like. So in terms of how this process works, this is a side view of a person. If you've ever had a swallowing test at the hospital, they will do an X-ray and you might see a view in this aspect. So one of the first things we look for in swallowing is what we call the oral preparatory phase. So this is the ability to put food in the mouth to close the lips and hold it. And in this photo, that little green shape is the bite or the sip. So you can see this kind of pink structure at the bottom. Underneath that is the tongue. It's a really huge muscle. And we have the palate, the red thing in the back that's kind of holding this bite in there while we might be moving it side to side to use our teeth to chew it. So that oral preparatory phase is kind of the first aspect. It's being able to hold and manipulate that bite to get it to a texture when we feel like we can transport it. So you can see this little green bite or sip is moving towards the back of the throat. Our palate is lifting to allow it to come back. One of the things that we really look for in swallowing is this pathway down below. And I'm going to show the folks who are, let's see, I don't know if my arrow will show here. This blue pipe back here, that's your airway. And the vocal cords sit on top of that. So you can see that the airway is wide open in this oral transport mode. The body really has to do a good job of holding on to that bolus or that bite or sip long enough to get it back there. And then the next phase is the pharyngeal phase. That's where we're moving it down. And you can see the airway is now closed off. We're going to protect it. So that's huge when it comes to our safety. We want the food and the liquid to go down past this little red guy here. And these colors are not probably indicative of what it looks like. But this space back here is the esophagus, which we'll see in the next picture. So ultimately, we want the food to go down. We want it to be away from the airway and to go down into the esophagus, which I'll move this photo for my... There it is. That little green bite and sip is now safely into the esophagus where it moves into the stomach to enter the digestion process. And this flap, this is the vallecula that's kind of up. It's like a trap door. It goes down when we swallow and it comes back up again. So we're primarily trying to get the food from the place it needs to be, but also we're trying to protect our airway while doing so. That's a real quick and dirty anatomy physiology lesson. There are normal age-related changes for swallowing. So there are things that we are all going to experience as we have the privilege of aging. And some of that is just reduced muscle strength. So that might be tongue strength, that might be lip strength, that might be the cheeks. There may be things that are just getting sort of weaker. And so chewing really chewy foods might get more difficult just by aspect of that strength sort of depleting a little bit. Some people actually get more of a dry mouth. So whether we'll talk about that in a moment, some pharmacology that could be doing that, but sometimes it's just less saliva produced. As we get older, we of course have changes to teeth. We might have some dental work. We might be having some extractions. Maybe we're having some partial or full dentures. That, of course, will impact the architecture of how we chew the foods that we have. Some people have changes in oral sensations, so being able to detect maybe hot or cold or different types of crunchier textures that might be just sort of diminished. Some people, as they get older, are not as hungry or not as thirsty as they used to be. And then some people have that esophageal phase, so some difficulty with the transit of food. If anyone here has GERD or gastroesophageal reflux disease, that can make some changes. And that can oftentimes have sort of like effects upward. So if I've got stomach issues or if I have reflux issues, that sometimes can translate to sensations of food getting stuck or not feeling like it's going down and staying down. So in terms of the dry mouth, there's a lot of medications that some people may have to go on where one of the primary side effects is going to be dry mouth. So we may have reduced saliva production just as a factor of age, but we then may also have some additional impacts. And if you've had dry mouth in your life, which I know all of us have at some point, the things that we might notice is we don't have as much movement of our tongue and our lips. Things are kind of getting stuck. It doesn't really feel like things are fluid, which of course then can impact how well we can chew and swallow our food. So all of these medications, if you're on them or your loved one is on them, we really want to be thinking about if we're noticing some swallowing issues, how much of this could be dry mouth related, and is the medication necessary, or how can we manage the dry mouth if we do want that medicine on board? So when it comes to dementia, though, we have some other changes that we really need to be watchful for. So just like we have changes in oral sensation, we may have changes in visual perception. So just the idea of where is the plate? Where's the fork? How much can I see of the food that's on my plate? Sometimes people, if they've ever had any maybe stroke-related activities, sometimes people miss huge sides of their sort of environment because the brain is just not attending to that. Some people may have impaired proprioception. That's knowing where your body is in space. And so when you think about eating and feeding yourself, you've got to be seated in front of a plate on a table. There's utensils. There's a lot of very fine motor movements that are incorporated into this. Reaching for a glass, for example. If your brain is not able to pick up on the distance, the proximity, these things can be more challenging. Some people, as their brain starts to continue to change, may lose the ability to use the utensil appropriately. So you might see someone picking up a knife when they really intend to have a spoon. They may not be scooping food the way that they need to. Some people have difficulty discriminating real food from non-food. So in certain types of dementia, we might see someone picking up, let's say, a button or some small object that might look like food, maybe looks like candy. So having some difficulty choosing not to eat things. A lot of people may say, I forgot to eat, right? That's where we get really concerned about just that executive function, planning for the day. Or some people forget that they've eaten. Their brain is no longer getting those signals from the stomach, like, oh, I'm feeling pretty full. And so what you end up getting is someone who may be eating more than they usually would, just because their body signals are not that loud anymore. And some people, especially if you're dealing with a behavioral variant of the frontal temporal lobe dementia, we have people who may be eating at a very fast pace. So that becomes a real choking risk where someone's just unable to inhibit or to stop the act of putting food into their mouth. Like I mentioned, there's the neurodegenerative process with dementia, but there's also stroke activity. Strokes, depending on where they are located in the brain, cut off the blood supply and can result in cell death. And so there are many diagnoses of stroke where swallowing becomes kind of that primary problem. And that's sort of a whole distinct class. We call that dysphagia as the medical term for any type of swallowing problems, but that's sort of its own. There's unique profiles related to swallowing impairments when it comes to stroke. For example, if someone has a brainstem stroke, it may become impossible to even initiate a swallow. That person might not be able to swallow their saliva. They may not be able to eat. So that's sort of its own category, but it's important to consider as a brain phenomenon. So when we think about the signs of dysphagia, I bet someone here could tell me, just based on this picture, like when someone's having a hard time swallowing, even yourself, what do we notice? Right? Go down the wrong pipe. We're patting someone on the back. We may be having some difficulty with, maybe chewing a food. Let's say it's a steak. It's really well done. Like, oh God, I just don't think I can get this down. So we've all had that experience of eating or drinking something when it doesn't go well. But it's pretty transient, right? It might happen, let's say if I have a real bad sore throat, right? It might hurt to swallow, but it gets better as my body heals itself. The signs of dysphagia that we're thinking of when someone's had a brain change, these are things that are ongoing. And it's not just a one-time occurrence. It's more of a pattern that we are watchful for. So some of the signs of dysphagia we want to think about is if this person is having difficulty just even containing the food in their mouth, right? If their lips are either weak or there's not a lot of sensation and there's sort of this like loss of food where we've got it on the shirt, it's on the face, it just doesn't really stay in the mouth. Obviously difficulty chewing solid foods. So maybe just by choice over time, we might be self-selecting, oh, I used to love salads, but I don't really eat them anymore. Or I'm eating softer foods more. I'm kind of turning things down that I know are difficult, which intellectually is good. If we're still chewing, trying to chew those foods and it's not going well, that's a different story. Towards the end of the process, we might see someone starting to hold food in their mouth. Again, that's sort of that swallowing sequence, the ability to say, oh, there's the voluntary part of swallowing where I put food in my mouth and I know I need to chew it really carefully, or I need to make sure that it's in a good texture so I can swallow it. Sometimes what happens is food is in the mouth and then it just kind of stays there. And we have lots of behavioral techniques to try to get that started, but it's almost like the swallowing process hasn't just clicked. And then of course, pocketing in the cheek, that might be common for someone who's either eating too much and they're just kind of storing it, almost kind of like a squirrel, or if someone has decreased sensation. This is very common in stroke. If someone's had any type of stroke activity where they just don't feel or they can't attend to one side of their face, they may have food that gets stuck along inside the cheek, kind of along the teeth. And it can be a severe problem, or it can be, pretty minor. They just clear it out as they keep going. These are things we want to watch out for. Similarly, if we think about going from, that initial phase of chewing and preparing and moving it, as we get into the pharyngeal phase, moving the food from the mouth into the throat, when we've got some changes, start again.
Yes, forgive us, everyone. We had a problem with the connection, and we're going to pause and reset it up. So I need you to that triangle right now, they can't see that on Zoom.
Okay. Fortunately, most of the text, the right side really is less relevant. Let me see. I guess I'd have to stop sharing the full view. Let's see if I went like, no.
Please stand by. We're working. Does that mean we lost everybody?
That would be bad.
Okay.
How about this? I think if there's any particular slide that someone would like to see, I think most of the information's on the left. I am happy to go back and reiterate anything that people feel like they're missing. You're a miracle. Okay, good. Okay, so we were just talking about the signs of swallowing problems. So as we think about the airway, remember that the body moves the airway out of the way. So if there's some sort of loss of the liquid or something's going down towards the airway, we might notice that maybe not in coughing, but perhaps in voice changes. So this person has a wet and gurgly voice. And I will say, I notice even my husband, who does not have dementia, he has this periodically, but he clears it out. So if you're sort of noticing this is not necessarily a super bad problem, but if it's something that you notice and that person is not clearing it out, and then they may be even going on to develop some kind of respiratory infection, what that might mean is food and liquid might be getting into the airway at some point. So recurrent upper respiratory infections are sort of a red flag for perhaps someone is getting sick. And we want to always look at, well, in the context, people get sick all the time. It's flu season, it's COVID, et cetera. But if we notice that we're seeing these difficulties with eating and drinking, and we're making some dietary changes, and we notice upper respiratory infections, that certainly is a red flag to indicate need for some workup. As is unplanned weight loss. Of course, when you go to the doctors, we're looking at weight. We want to maintain weight. We want to maintain strength. If there's unplanned weight loss, especially if someone's still in charge of, planning their meals or eating, that could possibly indicate that maybe some of that forgetfulness is starting to filter into how much calorie intake they're actually consuming. And of course, if they're not getting what they need, we're concerned also for signs of malnutrition. So in the event that you would see any of these signs, the speech language pathologist is the professional that really is the expert in swallowing evaluations. This is someone who can see you in an office, in a private practice, in a hospital. A doctor can write an order for a speech pathologist. And what the speech pathologist will probably do after doing an intake is what we call an instrumental evaluation. So we always say, I don't have X-ray eyes, but I can do an X-ray evaluation, right? So after an initial intake, we would do something like this. So this picture right here that you see has two different names. So a modified barium swallow study or a video fluoroscopic study, where essentially you're giving someone barium in various textures. So a thin liquid, a thick liquid, a cookie, a pill. And we turn on the X-ray to watch chewing and swallowing. So remember that little green bite or sip we watched in those drawings initially? This is actually what we would look at. So in this particular picture, you sort of see this dark black kind of, down into the base of the tongue, into the airway. That's the barium. So it's white in the real life, and it shows up as dark. And what this is able to show the speech pathologist is the actual physiology, what's happening in swallowing. Because I can look at your face and I can see how your teeth are working and your lips are working, but I really can't make a guess. It would be a guess until I can look in and see. So this is kind of what we would consider the gold standard to develop then a protocol to help with how to manage your swallowing problems. So if we notice that liquid is going down the wrong way, we would see it going in the airway. We would say cough or clear your throat, and then we may try some different postures or procedures. There's another swallow test that uses a camera, goes through the nose. So these are the types of tests that you would expect to see if you were going to get a full evaluation. And they're very useful to determine if there's been any sort of changes to how the body is functioning, and especially to find solutions to manage primarily airway protection. Yeah.
So I would imagine it'd be hard to get somebody that has dementia to actually cooperate with doing something like this, like swallowing different versions of barium.
Definitely. So we'll talk about that in terms of the other types of sort of things that we could do at a bedside. I agree with you. I think that these tests are, especially when there's been a neurological event like a stroke or a brain injury, someone has had maybe cancer, they've had some surgery. These are exceptionally helpful. A bedside evaluation, especially in a natural context. So if I came to your house and I sat at your table and I watched you, a really seasoned clinician is going to be able to get a lot of information without having to do this. This is helpful, I think, if we're really concerned about pneumonias and, airway issues. But you're absolutely right. This could be quite challenging. It's very quick. It doesn't hurt. Sometimes it's just because we're handing a cup. It can be very natural. So I've worked with a lot of folks who are very impaired cognitively for various reasons, and we can get this done. It's not a complex test at all. It doesn't require anything like, not eating the night before. This is a very easy test, but of course, if someone's distrustful, if someone's not really sure what's going on, I 100% agree with you. So the other thing we may want to think about when it comes to the professionals who engage in swallowing is an occupational therapist. So whereas the speech pathologist is primarily concerned with what's happening internally, looking at the anatomy and the physiology, the occupational therapist has a whole tool of assessments to look at when we're looking at feeding. So getting the food, from the plate into the mouth. And one of the things that's why that's so important is because, again, we're experiencing visual perceptual changes. We're experiencing fine motor changes. There may be difficulty picking up your standard utensils. The other reason why this is so important is because we know the swallowing process doesn't actually start when the food is in the mouth, but it's when we go to pick up that utensil or that cup and bring it to our mouths. Our brains are getting into this preparatory phase. So the swallowing process is best when the person is independently or with some support getting food or liquid into their body. So I would much prefer, let's say, having a trained partner, have someone pick up the spoon and bring it to their mouth so that that individual still is participating in the act of feeding. So the occupational therapist is another great resource. This is a therapist. You can get a consultation from a doctor to say, I'm noticing we're having difficulty holding utensils. We're dropping them a lot. These are tools. You can see in this case, this is a spoon with a built-up handle. It's very dark. There's a lot of good contrast there for fine motor. So the occupational therapist, again, is just a professional who, knows how to modify the tools in order to get the job done. So in terms of maintaining swallow safety, and what I will also say in terms of the evaluation process is I always think it's better to get earlier eyes versus later. Swallowing can change quite quickly, and once it changes, it really becomes, a main focus. We need to have a lot of supervision. We may need to have a lot of different tools. We might be modifying diet textures. So this is something where we don't want to wait too long. If we're starting to get a little feeling like, ooh, I'm not quite sure that eating is going as well as it had been. This is something where we want to ask the physician, and we want to make sure we get these rehab professionals in as soon as we can, just because it helps to ease the process. We can anticipate some problems and make sure that help is there to modify. So in terms of maintaining safe swallowing, I always like to say, let's talk about swallowing. And it's hard to say, sometimes people might not be, depending on their stage of their dementia, they may not be able to, but they might be able to offer some qualitative information. So you can get this, it's called the Eat 10. It's a swallow screening tool. Even if you are looking at it for your loved one, to rate how severe some of these problems are. So if you're noticing, wow, we're really struggling. Oh, and by the way, with any of these tools, I will make sure that Dawn and the Insight team has access to that. So I can send anyone a link that they're looking for. And I have another handout that we'll make sure to get to everybody. So just know that I'll have the resources for you by email later. But this essentially is a nice thing for people experiencing swallowing problems or loved ones sort of noticing. And there's a score that's produced, and that kind of helps to figure out, just to quantify swallowing a little bit better. Always, 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 we want to ensure that the sensory capacity is optimized, right? So if we're seeing someone who's having difficulty with seeing food on the plate or hearing, even to listen to their vocal quality, right? We want to make sure, how's the hearing? Is this person having hearing aids and they're choosing not to wear them because they're not talking, but they may benefit from that sensory input. Obviously making sure that if we have glasses, we can see the glasses. So I always think this is part of the first step of getting ready to eat, is ensuring that the sensation that we need is optimized. As a former hospital worker, it was always really frustrating when I would come in, I'd be working to, help someone with swallowing, and we didn't know where the hearing aids were, or the glasses were really dirty. And it's a worthwhile effort to make sure that those sensory inputs are there, because this is ultimately a sensory experience. Obviously, if someone has any type of denture, that is something too. We want to make sure that it's present and it's well fitting. I think that dentures, especially if there has been weight loss or things are uncomfortable, we want to make sure that that sort of like mouth environment is suited for the foods that we want to eat and consume. It's helpful to offer frequent reminders for hydration, whether there's dry mouth due to age or dry mouth due to medications. We know that the brain is a huge organ dependent upon water, and we know that dehydration can oftentimes accelerate or exacerbate cognitive impairment. And so really making sure that water is available. Sometimes this whole process takes a lot of creativity. But just to say, is this person maybe not drinking enough just because the act of saying, hey, I'm thirsty, I then have to get up and go to the kitchen and get a glass and put it in the fridge and get the water I need. Sometimes that's enough of a cognitive barrier. So we would say, let's just try to make sure that water's available. Frequently, if we have maybe a glass of water and a sign that says, take a sip or have, cheers, something that basically says, I want to have the environment be the cue. But maintaining hydration is so, so important for all of us, but definitely for folks dealing with dementia. Oral care is another thing that has huge implications in swallowing safety. So, brushing our teeth is something that we typically do independently. We wake up, we use the bathroom, we get our toothbrush. But as cognitive changes can occur, we might forget to brush our teeth, or we might not be doing the most sort of thorough job of things, flossing and brushing, depending on what someone's prior habits are. So when we think about oral care, it's to keep fresh breath, obviously, get food out of your teeth, but it's really about minimizing the amount of bacteria that can build up in your mouth. That's another reason why hydration and flushing that bacteria out is so important. When people are not brushing their teeth and they're maybe not eating and drinking, we have a lot of oral bacteria that can build up. And that bacteria can just march its way down into the airway, whether we want it or not. Or if someone's having some swallowing problems where they might be coughing when they're drinking, that oral bacteria can then enter the lungs. And that's where we get into a really dicey situation. So just having your eyes on, is this person brushing their teeth and how is that going? If we notice, maybe they're not brushing their teeth, that might be a way to kind of support and supervise. So a toothbrush, just standard toothbrush, toothpaste is fine. These oral swabs that are here, you might, if you've ever had to be in the hospital with someone, you might have seen these. These are not meant to substitute for the toothbrush, but what I like to use these for, especially if someone's having difficulty with maybe clearing out the food in their mouth because of weakness or inattention, is these little swabs are just so nice to be able to get back in there and kind of clear this part between the jaw and the cheeks, because we want, again, decrease the amount of bacteria. So if you notice someone as you're talking to them, they've got like scrambled egg from breakfast and it's, 11 a.m., you might say, ooh, okay, I might have to kind of get in there. Or I might have my person say, try this out. And kind of, it's like what we would do with our finger, but it's a little bit, just a little more effective, I think. So you can get these on Amazon. But again, they're not to be substituted for good old-fashioned toothbrush. I will also say if there's any folks here who are dealing with periodic hospital stays or a nursing home, oral care is something that there's a lot of great ideas and protocols, but we really want to meet like the oral care police just to make sure this is really getting followed, because again, it's about health and safety, but it's also really about comfort too, right? When our mouths feel yucky, we don't feel so good either. Other thing to really think about here is distractions. So when you think about going at this table, obviously is a pretty silly indication of, just how distracting. Think about how many cups, how many plates, how many bowls, how many people, how many conversations, right? A lot of us may have the TV on or music going. Especially if we're still going out to a restaurant, there's a whole host of activity that's going to be competing for our attention to eating. And so when we're looking at distractions, we really want to think, and this takes a kind of a mindful pause to be able to look at not just the food that we put on the plate, but what else is happening in this room, right? Where is my attention going? Am I drawn to the TV in the corner? I might have someone switch seats with me, right? So where maybe they're looking at, the booth or the wall behind them. So thinking about, what is this environment like? How much activity is happening here? Do we have our phones on the table? Obviously we want to take those away, even the newspaper. So a lot of people sort of, they'll watch a show and they'll eat, or they'll be reading and eating. And that's really a complex cognitive activity. So we want to be watchful for distractions, even lovely social interactions, if we're really worried about someone's ability to focus on eating. I could see a scenario where someone's so excited to go out with their girlfriends and their family, and they sit and they go out, and because they're so engaged in talking, they just forget to eat. And now we're like, oh, wow, she didn't eat any food on her plate. It's because she prioritized socialization, right? Which is great, but not good for nutrition. So there's a lot of things that we try, right? And this kind of gets into what you were saying, like The instrumental evaluation is obviously the medical practice, but a lot of this is what we would consider cognitive behavioral. It's saying, what can I do to really make sure this brain can get this task done? So sometimes it's a matter of making sure that you just have a very simple structured place setting. This could be something you could set as a placemat. Sometimes it's actually a nice cognitive focus where you might say, hey, will you set the table for us? And now this person knows where to put the fork and the napkin and the knife and the spoon. Or even to set these things down so that, again, if that visual perceptual or that sort of motor movement is diminished, we at least have standard placement of objects. When I worked in the hospital, I would see the cafeteria bring up the trays and they would set the tray down and there'd be like 7 plates and, a water cup and a teacup and sugar packets and lemon. And we would just, for those folks who really need a low distraction environment, we would just clear it all away and we'd say, I brought you your fruit. And we would have it almost like a course, right? So it's a 7-course meal, but it's not all at once. We're really trying to make sure that the focus is just on that one item at a time. It can also be overwhelming for someone who maybe doesn't enjoy eating as much anymore, where if they see all this food in front of them, they say, oh, I can't, it's too much. Where we might say, no big deal, we're just going to kind of give you a small amount. And if they eat that, be like, oh my gosh, I got some more in the kitchen, and bring out a little bit kind of in a paced manner. Another thing to think about is high contrast dishware. So if you have white plates like I do at home and you're eating pasta like we love to eat at my house, there's not a lot of contrast there. So as our sensory changes are occurring, this person might not actually be able to see the food on the plate. So maybe a red plate, the food is a little bit more visible. And this is kind of an easy fix, right? So if we have white plates, we might just try swapping that out. If you are dealing with visual perceptual challenges in other aspects, like in walking or in the bathroom, OTs and PTs will also use this sort of high contrast. We really want the brain to be able to see what's in front of it, so these motor patterns that we're trying to facilitate can happen. So this is sort of a nice contrast. I will say there's also a ton of if someone's really, let's say, has a hemiparesis, maybe they've had some kind of change to their brain where they're not using one arm. There's plates that have like a built-up edge. Again, that's where your occupational therapist really shines, as they can say there's a whole host of plates and foods. But even for, let's say, motor is working, but we're just not eating as much, we might want to just swap out for a red plate or a black plate. And finger foods are great too. So if we're starting to notice some difficulty with utensils, we're not going to continue to serve things that require a lot of cutting and twisting. And, we just say it's okay. We'll just modify and think about some finger foods. These things might be just a little bit more intuitive. There's a lot of foods that people like to eat, and we could just find them finger food style. And again, this takes some creativity. We want to experiment also with temperature and flavor options. So if we notice that someone is really not eating the way that they used to, it could be that that sensation has decreased or that sense of fullness. And so we might say, you know what? Maybe they love ice cream, right? And maybe I noticed they really do like that cold, sweet. People typically like sweet things. So we might be actually just playing around with some of the flavors of the foods and seeing what they like. And again, it may not be consistent. You might be like, yes, okay, strawberry ice cream, we got it, we're there. And then next week it's like, I don't want this. What are you talking about? But I think that in this case, we really want to say, well, what do we notice? And this again takes that view of like, I'm sort of stepping out of just being a meal companion. And I might notice maybe I'm using a tracking sheet, or I'm having a family member help me to say, like, what do they tend to really like these days? What do these foods have in common, and how can I make sure that we are capitalizing on that? I will also say that sometimes it can be a way to collaborate. So if your person is still able to participate in maybe meal prep or choosing things, we might ask them, oh, hey, do you want to help me with this spice? Let's think about trying something new. So this is very much in that sort of like life participation focus. Your concern is that they're getting the calories they need and they're eating safely, but they might want to participate in that with you if you're saying, hey, we're going to take found a new recipe online. Let's test it out. So if you see a speech pathologist, they might say, okay, here's some strategies, try this out. And you're like, great. And then you go home and you're like, wait, we're not doing it. One of the techniques that I just want you to know about, not that you'd have to do it, but I want to teach you about, is something called spaced retrieval. Spaced retrieval is essentially a learning technique for people with memory impairments, and it works really, really well, even for folks who have pretty significant memory impairments. Again, it's a therapeutic technique. You'd want to have a therapist help you out with it, but the basic gist of it is I ask someone to do something, right? I might say, what do you do when you swallow? I tuck my chin, for example, or I'm going to swallow twice, or I'm going to take a sip of water. And you say, great. And then you let 15 seconds go by. And you say, what are you going to do? I take a sip of water. And sometimes a written cue is helpful. And you're basically just pacing that out. Every time they get it right, you double the time. So maybe it's 30 seconds becomes a minute, and a minute becomes 2 minutes. But it's this idea that the brain needs a lot of practice to learn a new technique, right? So what cup are we going to use? We're using that cup. And you basically want to just load that up. So these swallow remedies that we also have cognitive supports or cognitive strategies that can help with that. So again, what are you going to do? I'm going to take a small bite. And then you go ahead and you see them taking a huge bite and you say, what are we going to do? I'm going to take a small bite, right? So some of that might be maybe for someone who's maybe an early moderate. If someone's really at the end stage, this might be unrealistic, but these are good techniques to know about and to look for when you're working with a speech therapist. So if you end up becoming in the speech pathology community and you have a therapist who's guiding you, I want you guys to know about diet texture modifications, because this is something that's been very standardized by a huge sort of international dysphagia initiative. And again, if you've had any interaction with the hospital and if you've had to change liquid consistencies, this might look familiar to you. But essentially, we have all of these foods, and each one of them has been studied based on how easy it is to chew it and swallow it. And so they give it a number, right? So a regular diet, a salad, piece of toast, soup, pizza, what have you, that's going to be a 7, right? As someone is starting to experience difficulty with chewing, it's not like we have to puree everything right away. We've got some nice medium steps in between. So what I love about this website, and again, I'll send you guys all the link, it's listed at the bottom, is there's education sheets for families. It's like, these are the foods that are in this category, and this is how you know what this food, if it's at the right texture. What had been happening prior to this was it was basically kind of guessing. So someone would be, let's say, on a mildly thick liquid, which moves more slowly, right? So for someone whose pharyngeal swallow or oral swallow is not working so well, we want something that moves a little more slowly. If that's been found to be the best option for them, we would have no way of knowing if my mildly thick was your mildly thick, right? But now they've done a lot of standardization. So this website has all these PDFs and education sheets. So you have a little bit more options if you want to try to modify the diet on your own. Again, speech pathologists are really great to help out with this. And what you see is that drinks can go all the way up to extremely thick, to pureed, which that has its own thorny issues, but we have options, most importantly. Yeah.
Our neurologist said even the thinnest liquids can be the most difficult. So
Yes.
Is that what that's inverted?
Yep. Thin liquids is 0. Yes.
So the 4 is the easiest, whether it's food or drink.
I wouldn't say it's the easiest. It kind of depends, but it's sort of like the most modified, if we could think about it that way. So like an extremely thick liquid is essentially a puree. So that might take a lot of work. Whereas maybe thin liquid, yes, it is sometimes the hardest. So if I took a sip of, let's say, a slightly thick or a mildly thick, that might be easy enough. I don't have to do a lot of preparation, but I can just swallow it down and it moves at a pace that sort of matches with mine. And that's where that X-ray swallow test does actually come in handy, because you can see, do I need to thicken this? There's a sort of a philosophy that thickened liquids can be beneficial in that they may not be going down the wrong way, but there was oftentimes an overprescription of thickened liquids where people don't drink them and then they become dehydrated. And there's some theories that people, when they have, let's say, a clean mouth, we've decreased the bacteria in that oral cavity, and then we give them water or ice, even if it goes down the wrong way a little bit, and they're not having like a big prolonged cough, that they actually can tolerate water in the airway versus, let's say, thickened Diet Coke, right? So this is, again, where you should never enter this like blindly, but a therapist can really help to guide this process. But you're absolutely right. Thin liquids. I have a client right now, she's 86, and she really loves water. She can't hold it in her lips. It goes down the wrong way. She's coughing. She's really suffering and struggling to clear her airway. She's a great example where that is the hardest liquid for her. Yeah. And so like I just mentioned, so liquid modifications, there's definitely a room for knowing where can we have water. Sometimes we may say, you know what, we want to have hydration, but we're going to do it in ice chips. Or we might have it let's say in between meals, because we want this person to stay hydrated, but when they're drinking water and eating food at the same time, it's like a mess. You know, the residuals of the food are getting washed down. And so again, this is where a therapist can kind of help guide you. There's a really nice food thickener that's available. It aligns with those IDSI recommendations. And so these are just options, right? The other things that are available too, again, a therapist can help out with are cups. This is a cup and a straw that can control how much the person is drinking at one time. So especially helpful if we have someone who's like just guzzling, taking big, big sips one after the next, and it's just not going well, but they can't necessarily regulate that. This is a cup where basically I could tip it back all day long. I'm only going to get basically a teaspoon or 2 teaspoons. So these, again, I would not purchase them just randomly. I would work with a therapist, but these are available. I've also had success with giving someone, let's say, a travel mug that has the lid open and a little tiny hole where it's not necessarily like a dysphagia cup, but it does the job of slowing things down. Again, you would want to do that. This straw is helpful for someone who might be struggling with a straw. Straws are like, ooh, because it's a big sip. You have to hold a lot in your mouth while you're drinking it. And this is a tool that kind of holds the liquid there. So these are just, again, specialized devices to help with that process. So there's a lot of changes that can happen over time. Some people never have to make diet modifications. Some people just, they're able to eat the way that they are. Some people, they can modify a diet and that's the diet they're on for a while. But as someone is really coming to the end of their chapter with dementia and maybe eating is really changing a lot, we want to kind of review some end of life considerations. And in this sort of like life participation philosophy that I have is we always want to start at the end. In other words, I want people to be able to make decisions about what they want and what's important to them and to their family while there's no crisis happening. So these conversations are sort of nice to know, what are people's wishes? If eating and drinking got really hard for you, what would you want to do? And there's really a very highly established consensus from the American Geriatric Society. I was actually looking for some research, and this is from 2014, which feels old, but I think essentially there's not a lot of new research happening because this is the consensus. So when eating difficulties arise in advanced dementia, feeding tubes, which is a tube placed either in the nose temporarily or in the belly, is not recommended. And I think this is a really challenging subject for people because when we don't see food or liquid going in our loved one, it feels like it's wrong, right? It feels like, oh my gosh, they're going to starve. What's happening? I want them to get nutrition. But there's a lot of consequences with a feeding tube. So if someone's eating has decreased so much where they're not taking their liquids and they're not getting the nutrition they need, it's tempting to try to replace it. But the feeding tube is oftentimes associated with an increase in agitation. So now we've got to sedate this person, or we may end up having to restrain them physically or chemically. There's a lot of health tube-related complications. If someone's mostly in bed and they're getting a feeding, they can reflux it into their airway. So there's not really a prevention of aspiration in this case, and pressure ulcers. So I think it's, everyone has different philosophies, but this is really, I think, what care teams who are caring for people with dementia will really universally say. But then what does that mean, right? So it's hard. It's a hard situation to encounter. One of the things that I think is helpful, and I've helped some clients with, is this concept of comfort feeding. So comfort feeding is typically when their eating has changed so much, perhaps they've entered hospice, their body's needs are starting to change. And so this idea of having 3 meals a day, I have to eat my protein, I got to get in my fiber, like that's not really the concern anymore. The body may not need it. And so what comfort feeding focuses on is just connection and offering comfort. Rather than meeting specific nutritional goals. So in this case, there's really no need to be preparing and, oh my gosh, he's got this oatmeal, he's not going to eat it. It's 4 ounces. The doctor said he should have it. The idea is that even just offering that to say, do you want to have a little taste of oatmeal? If that person has 1 teaspoon, or maybe they had 5 teaspoons yesterday and they don't want it today, everything is okay. We're just doing it to offer comfort. Even getting ready to eat, to sit down and eat with someone. Maybe I bring my coffee over and I sit at the bedside, right? And I have them smell it, if that was something that they enjoyed. Or gestures like just taking a wet washcloth and kind of wiping on the lips. That these are all things that are sort of equating to the comfort that we get with eating, but we're really just sort of saying, I'm not concerned. The body is doing what it needs to do, and I don't have to be so on top of this. And again, this is in the context of being cared for by a team, but I just think it's okay to know that mindset to say this is the safest alternative that I can have for my loved one when eating and drinking becomes really too challenging. I had a family that I was working with, and their loved one had cognitive impairment. He was doing really well. He had a really good routine. He loved sandwiches. He loved coffee. And then he had a fall. And the fall really accelerated his cognitive decline. And he ended up really never getting back to the routines that he had. And his wife was so stressed out. She was really like, oh my gosh, because it felt like a fall. It was like, well, it's not like the dementia has just advanced, but what had happened was his health status had changed. And so we had a conversation. The hired caregiver was really trying to give a lot of food and wanted IV fluids, and he was really struggling too. And what we just said is, what if we just shifted our perspective? And we just looked at comfort, right? We just want to make sure that we're not forcing him to do something, because if you've ever tried to give someone food who really can't swallow it, that does feel uncomfortable. So if we shift the perspective and we just say, what would make him feel good, right? Maybe he wants to smell something nice. So maybe we have a candle, right? Where it's like smelling like apple cinnamon. Or we are, again, addressing that oral hydration with like a cold washcloth or something like that. That's okay. The body is going to do its process, and food is not really the primary source. It's really the connection and the support. So these are hard conversations to have. I have a handout. Again, I'm going to make sure everyone has the resources, but a handout that I made for this family, and it was just really useful to have. So I always say we want to think about these things not in the crisis of the moment, but just ahead of time. Just like, have this in your back pocket. Maybe there's someone else who's going through this and they're suffering. And you can say, you know what? Have you learned about comfort feeding? That's a really nice way to propose, right? So I had this own experience with my grandmother, who had a very sudden shift in her health, not dementia related, but that sense of, she was in the hospital. She would ask for something. We would like run and get it from the cafeteria, and we bring it to her, and she was like, no, or and I was like, okay. So maybe I put a little at her lips, and that was it. And she passed away. It was her time to go. But it was really that ability to say, I want to try, but I'm also not having any expectations here. This is just the process that we're going through. So with that, this is my contact information. I love to provide resources to families. So please let me know if there's anything that you heard today that you think is interesting, that you'd like to know about. I'm happy to make sure you have the resources that you need. Certainly in Northern Virginia, we have a lot of medical systems too. So even knowing like, what do I ask for? How does this work? I'm happy to support you guys.
Thank you so much, Lauren. We appreciate you, all of this expertise and the details. I want to make sure that we give a little bit of time. We have about 7 minutes if there are particular questions online. I don't have any specific questions now that we've managed the slide situation and that we can see everything. Are there other questions for Lauren that you have from the presentation or from your personal experience? Please feel free to type that in the Q&A box. Since it's a webinar, the chat isn't completely open. Just want to make sure that's available, and I'll pause for that.
And we have a question in the room here.
Question.
My husband is eating pretty well. He needs some help cutting his food up and so forth. The problem I'm having with him is trying to get him to take pills. Any suggestions? I mean, sometimes he will, sometimes he's swashes them around in his mouth. He'll spit them back in the glass of water. I've tried putting them in his yogurt or something. He'll find them.
Oh yeah.
So,
yeah. So the first thing I would do is I would talk to the doctor of those, of course, yes, but I would say of these, I'm a huge fan of really bringing our advocacy to these medical appointments to say, this is my primary concern, right? We've got portals. I need you to help me figure this out. Some of it is there may be medications that this person's been on for a long time that we can get rid of, which is good for polypharmacy avoidance, right? We have so many medications. Then you might say, are any of these medications available in another form, right? Is it a cream? Is it a patch? Can I crush these medications? If you crush them, it's less likely to dig them out, right, out of there. I would also look at the timing of some of these medications. Sometimes people have a greater difficulty maybe at night, or, there could be something else. Maybe they haven't sort of primed their swallowing. So you might say, let's have a couple bites of cereal and then we're going to try the pills. There is something that is available commercially. I have not personally tried it, but it's basically like a gel that can kind of go around the pill. So kind of the way you would do with like yogurt, if you're mixing it in, but it makes it really slippery. So I can find that product and see if I can get the link for you. But this is definitely a team effort. You might go to the pharmacist. Maybe the doctor's really hard to get in touch with, but you can go to CVS or wherever you get your medications and say, I need help with this, right? Pills are really tricky and the medication is important, but this is about sort of getting super creative. So you might have to prioritize, right? You might say, of all the pills he has to take, which is the one I definitely want to get in there, right? And how can I make sure that format is helpful? Like I'd mentioned in that swallow study, if anyone's having difficulty with pills, we actually have a barium tablet that we can give to someone and see if possibly that's the issue. But you don't need to do that X-ray test. You can probably get creative, right? And try to troubleshoot it. But bring in those people who are medication professionals, right? Because they might have some little sneaky trick that works.
Thank you for that. And that question was specifically, can you help me with someone who's not able to take their pills? How do I help them take their pills? We have a second question online here. The question is, my husband has Parkinson's. He has told me he is having difficulty swallowing. I cut his food into small pieces. Any suggestions?
I think especially with Parkinson's, there's a good amount of research that looks at sort of respiratory muscle strength training, which is a very fancy way of essentially saying supporting the pulmonary and swallowing mechanism. And so if you're not seeing a speech pathologist and you're noticing these difficulties, I would enlist a professional, because what it might be able to help you with is not only diet modifications, but also any strategies that he might be able to work on to really protect his airway. There's a lot of good research on that for the Parkinson's community in particular. So again, it's a lot of the recommendations we talked about. It's making sure the distractions are minimal and the food texture is optimized. But if you haven't gotten a speech eval, I would definitely seek that out.
Thank you for that. And our final question online says, my dad has a lifetime of terrible eating habits. Now he has dementia and has gained a lot of weight and is pre-diabetic. How do we help him make healthier food choices when he is really past the point of self-control?
Oh man, I empathize. That's really tricky. The first thing I will say is manage your own expectations, right? I hate to say it, but sometimes people just don't change. And it's when there's a dementia process at play, healthy eating is always important. But I would say be gentle for yourself and your efforts. If this person really truly is making bad choices, the likelihood that they're going to be embracing, like smoothies and, raw foods is really unlikely. So don't try, right? You try to do a little bit the way that you can. I always say like sneaking in some let's say fruits or vegetables, it may be in a context that they like. So if I'm making chili, for example, and they really love chili with cheese and sour cream, I might try to blend in some foods in there just to try to create a little bit of healthier eating. If this is someone who's maybe going out and getting fast food, I think some of the things are, can you help them make the best choice that they're able to make? Sometimes it's just a matter of saying like, yeah, we can go to McDonald's, but maybe we're going to try to choose a different way of ordering. But also I recognize this is just something that's probably a lifelong habit. And I always say with lifelong habits, sometimes these cognitive impairments just turn up the volume. So your main concern is to maintain the relationship and try to do the best that you can for this individual.
Apparently, there is one more question online.
Okay.
Essentially, how can you encourage someone with dementia to not overstuff their mouth?
Okay, so I actually have a client with this right now, and it's actually it's pretty scary. So one of the things you want to think about is education and reminders and talking about it only goes so far. So of course it's helpful to say, just remember to, take your time. Ultimately, what I'm doing with my clients is we are modifying the texture. So she loves cheeseburgers. And so what is a cheeseburger but one huge bite, right? So what her caregiver is doing is just cutting it into quarters, and then setting one quarter down on her plate at a time. So again, pacing it out. So there's not a ton to stuff. She's also having some of this behavior in restaurants. So we're really talking about, are restaurants the best place to be eating anymore, right? Sometimes it's a matter of just minimizing how much is available. But this is something where if you are repeating the same direction over and over again and you see the behavior is persisting, it's because talking doesn't work anymore. And now we have to modify the environment. Sometimes it's about changing the texture. So I might say, oh my gosh, I made this, burger, how can I make like a burger stir fry, right? Where maybe I'm taking the ingredients and I'm modifying the textures. So they have the same food, but it's going to take them longer. The bites are smaller. But keep an eye on that, especially this is also about kind of like supervision. So the client that I have, she would eat in front of the TV alone. And we were really saying like, that's probably the worst place because her attention is on the TV. We really need to try to enhance the focus and, maintain that supervision. And if you need to pull in support for that, that's a great reason why, is just make sure that that person is not going to choke.
Awesome. I want to respect our person who showed up. So we got a question here in the room, and your question is?
My question is similar to the person who talked about their father with a lifetime of bad eating
Mm-hmm.
except it's the opposite. My mother has a lifelong preoccupation with becoming overweight.
Oh.
She's 91 pounds full of clothes.
Mhm.
And it's such a struggle to get her to just, it's still a conversation, but now it's, now it's even worse.
Yeah.
To eat.
Mhm.
I mean, in that case, a lot of like the caloric tips are typical, and I know you know this, I'm just telling you what you know, but like, adding in oils and creams and fats and foods to the textures that she likes. So sometimes that can be done and sometimes it can't. If she likes a really like yummy, healthy smoothie and you're just like plunking in, all the protein powder and everything that's in there. Sometimes it's also about switching this idea from like a big meal, especially for someone like that, where you might go to more like snack mode.
Yes.
Like we are snacking and oh my God, I'm having some. Do you want some too? And now we're having this small amount where she doesn't feel like, oh my God, I'm going to get fat, right?
Yeah.
Which is a terrible, but a long entrenched probably belief system for her. And it's really about shifting that around. Sure.
Water is really hard. What's the conversation? I keep seeing things about these hydration gummies.
Yeah, the little like drop things.
Yeah.
So if I would try it out. I think again, all of this takes a lot of trial and error. So these are basically like they're colorful and they're hydration kind of gummies and they can hold them in their mouth. I would give it a try if you can find them.
Okay.
I would also try maybe adding like a splash of juice. Like, is she into like other flavors? I just had a client, again, not drinking her thickened water. And the dietitian, although she was like pre-diabetic, was like, go for juice because she would drink juice and she can drink juice. So you might think about like, yeah.
My husband's neurologist, the same question.
Mhm.
She said encourage him to eat a lot of fruit, that it has a lot of water. She likes apples and stuff like that.
Watermelon is a great one. Yeah. So that's another thing to think about. Thank you for bringing that up. There's a lot of foods that have water inside of them. Sometimes what gets tricky if chewing and chewing is an issue, but you could cut that up, but you may be able to get actually a good amount of hydration. Same thing with like a smoothie or soup, or if there's something else, you can actually count that kind of towards not just the food, but the water, the liquid intake as well. Oh, yeah. I'm going to stop. Okay. Yeah.
So somebody else joking, if it's liquid or solid. Maybe if it's solid, you do the Heimlich,
Yeah.
but if it's not, if it's liquid based, do the Heimlich. I mean, just patting on the back help, and
You're going to just let them cough.
body's naturally going to try to expel whatever.
Yes. Yeah. So the difference between choking and let's say aspirating. So when something goes down the wrong way, right, and it's a liquid, it's not actually occluding the airway. It's in the airway and it's irritating the airway and the airway is responding. And so you just want to give that person space. A lot of times people say, oh, have a sip of water. No, stand back, let this person cough, right? Make sure they're safe. don't necessarily give them anything else. And I always say, like, catch your breath, you know, like listen to your voice. How is it sounding? So the cough can be sort of you know, not a quick event, but you know, one that goes over time. So you want to just make sure that they're sort of back to their baseline before they continue to eat and to drink. Obviously, food stuck in the airway where it's closed off, they're choking, universal signs, that's big time Heimlich. Yeah, but that aspiration, you know, that's a little bit, you know, choking we can all see is super scary, and that's an emergency. The aspiration can look less scary, but is still concerning, right? So if someone's always clearing their throat, they're always coughing a little bit, we notice that, you know, sometimes like if you've ever been with a lot of people after the meal, you hear a lot of coughing and throat clearing because just digestion wise, that's what we do. But if you're giving someone something to drink and you see them coughing right away, that's a red flag. That's time to say, I'm not so sure. Let's get a professional in here and figure this out. Once they figure it out, they can also be helpful to figure out, you know, what is this texture? That's what I'm saying. A speech therapy evaluation is so useful because you can say, is it the size of the cup? Is it the size of the sip? What position do they need to be in? So a lot of that is helpful to go through with a professional who just knows what they're looking for.
Thank you so much. We're so glad to have Lauren Swabish with us today. You know, on the screen, there's also information for Insight if you want to contact us. We also have a QR code and emails and all the things. And then also, if you have specific questions for Lauren, you can ask me those, and we can work between each other to get that information out to you. We thank you everyone for being here with us online. Sorry we went a little bit over, but we hope that you have a good rest of your day.
You're welcome.